and Dr. Arruda are going to give a nice talk on their research projects. And to kick things off, we're going to discuss some central cord, spinal cord injury cases. Jared Cook is going to present the first case.
All right. All right, hi, I'm Jared Cook. I'm orthopedic spine fellow trained in Las Cruces, New Mexico. Are we able to see my slides? Yeah, all right, kind of looks like it. So the first case was it's a 77-year-old male. He had baseline gait instability that ended up falling on his face, had neck pain and stiffness. Previously, a few years ago, had a non-displaced C4 fracture that was treated in a collar. Does have a history of ankylosing spondylitis. So here's what it looked like at that point. You can see that C4 fracture, and then now at the new presentation, we have this significantly displaced odontoid fracture as well as a C6 fracture. And so this one was treated for both pathologies, went from C1 to T3. At that point, the patient's actually doing well from a spine standpoint. Is about 2 months out now. They wanted me to touch on an overview of central cord, so wanted to spend a little more time on that. So central cord is the most common type of incomplete spinal cord injury. It affects the upper extremities more than the lower extremities. Bimodal distribution. In age, about 1,100 new cases per year in the U.S., and generally there's pre-existing cervical stenosis and followed by a hyperextension injury. So anatomically speaking, it's been thought that this is central cord syndrome presents because of kind of what you see in these pictures, just the location of the upper extremities and the lateral corticospinal tract. This has been called into question lately, especially since the impact comes from the outside and the tracks are actually not as clean as these look based on more recent studies. So your treatment options are non-operative versus surgical. Unfortunately, there are mixed results that we see in studies. One of the things that we see is that younger people tend to do better, but studies on that show long-term outcomes, generally show that non-operative treatment and operative treatment on a longer timeline, 2 years out or so, actually are functionally equivalent. Although the early surgery patients tended to do better in the first few weeks. So, one of the things that's been studied is how early do you want to get to them? Like less than 24 hours, greater than 24 hours, does it matter? And currently there's no consensus, and the surgery is it's essentially recommended very strongly for obviously instability and ongoing spinal cord compression, but in the absence of those things, it's still unclear. So right now we have a clinical practice guideline from AO. Recommends decompression less than 24 hours after injury for central cord syndrome, even without mechanical instability. But the level of evidence is low, and it's listed as a weak recommendation. But that is, that's what we're working with at this point. One thing to note is that, we do have some information on, prognostic factors. And so the people who have more significantly impaired exams, patients over 65, fractures, dislocations, presence of hematoma, ongoing cord compression, and elderly patients with significant comorbidities tend to not do as well, after this injury. And other people are going to be touching on other aspects of spinal cord injury, so I'm going to leave that to them.
Appreciate it. So just really quick, wanted to get some input from our colleagues in Brazil. So Zach, why don't you get up and get your presentation going? That patient actually had a pretty displaced posterior C2 fracture, and then in addition had the fracture below. What are your thoughts on early treatment on a case like that?
Well, first of all, thank you for having us. I guess I'll speak on behalf of my group so we can move on. This is a very good case presentation. And first question is, we can clearly see two different images. Was that a CT scan that the patient had before trauma? Or was that a CT scan that he had on arrival, then he displaced at the hospital?
So the first image was the non-displaced C4 fracture that the patient had previously a few years prior.
Okay.
The image immediately following that with the C2 and C6 fractures, those were the new ones.
Because it is not rare for ankylosing spondylitis patients to have a missed cervical injury at presentation, and sometimes even be dismissed. So if we don't have high quality CT scans, like sometimes we do have in trauma, patients can be released and develop symptoms later. Here we try to operate patients as early as possible for these cases. If it is central cord syndrome without bony injury or without an evident ligamentous injury, we tend to perform laminoplasties on these patients. If this is an injury that has, of course, in this case has a clear instability, but in the non-ankylosed spine, this is sometimes questionable. Then usually we follow with a long decompression and fusion from the back. If the patient has both injuries, we tend to fuse them from the back as well.
Yeah, that's what we ended up doing, because of the displaced odontoid fracture and the spinal cord injury, we did an urgent reduction in instrumentation. So Dr. Tatarin is now going to discuss another case. This patient had pretty severe myelopathy, not necessarily central cord, but he's going to discuss and manage. And again, for a case that we just discussed, I think the other risk factor the patient had was some cardiac issues. So a lot of these patients, they're over 65, they've got hypertension, diabetes, cardiac issues, so the approach makes a difference.
Hi, I'm Zach. I'm one of the neurosurgery spine fellows here at Swedish. This patient is a 65-year-old gentleman. He's a healthy gentleman with previously independent with a year of progressively worsening myelopathy. He's a Neuric 4. He's barely ambulatory at this moment. His exam is up there. Preoperative imaging, plain films, MRI shows numerous areas of compression. The most severe at 4 or 5 is the axial slice on the right. Pre-op CT scan. So severely myelopathic, this scan, surgical options. We ultimately decided to do a 2-level procedure. Part 1, anterior approach, C3 to 7, 4-level ACDF. Part 2, C2 to T1, Lamy posterior instrumented fusion with bilateral C4-5 foraminotomies. These are the intraoperative films. This was a case we did a couple weeks ago. Post-op imaging, excellent correction, good hardware placement, good decompression. Patient did well post-operatively, save for some resolving swallowing difficulties and bilateral C5 palsies in spite of the bilateral foraminotomies, but this is resolving. So this is the pre-op imaging, post-op imaging. Looks pretty good. So I was asked to briefly touch upon the medical management of central cord syndrome. So the main goals of medical management: prevention of secondary injury, neuroprotection, hemodynamic management, and abating the inflammatory response from an acute spinal cord injury. So the main 2 tenets of this are MAP goals, or basic ABCs: rigid collar immobilization, safe, stable intubation, fiber optic, etc., if necessary. But in terms of MAP goals, there is contradictory evidence, but the current recommendation from the AANS and CNS is to avoid hypotension, poor prognostic factor, target MAP between 85 and 90 for 7 days post-injury. So 7 days elevated MAP goals. Second, more controversial one, whether or not to use steroids, methylprednisolone. So the mechanism of action of methylprednisolone is it interrupts the inflammatory cascades, inhibits cell membrane breakdown, so neuroprotective effects, maintaining cell membrane integrity, improving blood flow to the site of the spinal cord injury. So in terms of the evidence we have for this, the NASCUS trials came out between 90 and 98. I'm sure we're all pretty familiar of, but investigated efficacy of high-dose methylprednisolone in acute spinal cord injury. Based on the results of this in 2013, CN issued a level 1 recommendation against the use of methylprednisolone for acute spinal cord injury, citing the fact there's literally no class 1 or class 2 medical evidence to support the use of it. There's some inconsistent class 3 evidence, likely related to random chance, and there were significant harmful effects to using NASCUS dose steroids in acute spinal cord injury. However, in 2016, AO Spine suggested administration of 24 hours of methylprednisolone, recommended against 48 hours, but it had to be within 8 hours of injury. But I didn't, so that's.
Thanks,
what I
Zach.
got.
Nathan, do you want to get up next? So just real quick, Jens and our colleagues in Brazil, what do you think about the C5 palsies on that patient? Jens, do you think, was it blood pressure and why bilateral? Or do you think it was just ischemia, or do you think it was just trauma from the surgery?
Yeah, this is great that you selected this case. This is a patient of mine, and I'd like to ask our colleagues in Curitiba, and such a great group. I was a visiting professor there a couple of years ago and could see what amazing work they do. So Emiliano, Luis, and partners, this was not an immediate cord injury. This was a severe myelopathy patient. We did a surgery under NASCUS-2 steroids preemptively. We had no signal changes, and we used his MAPS above, or we held MAPS above 85 throughout the case. He did that beautifully, minimal blood loss, nothing dramatic, and he developed this post-primary C5 palsy, as you heard. So 2 questions. First of all, steroids, yes or no, in high-dose NASCUS kind of administration within 24 hours? And secondly, MAPS. So maybe we can just tackle that sequentially. So comment on, if you will, steroids and MAPS.
So Luis, would you like to comment on how we've been managing steroids protocol here?
Yes, thanks. We have been using very exceptionally corticosteroids for the set of spinal cord acute traumatic injuries, especially based on the recent literature. We think that the patients coming in admitted within the 8 hours after trauma, and patients that were in the groups included in the NASCUS groups, benefits of the. But especially for this case of the myelopathy, it's very rare that we use this type of protocol. We use some, I use personally some corticosteroids, especially if the patients develops any symptoms of C5 palsy, but not in the protocol of the NASCUS.
Yeah, if I could comment on that from the regulatory points of view here in Brazil, the Brazilian Medical Association on a joint committee with the Brazilian Spine Society, Orthopedic Brazilian Society, and Neurosurgical Society defined against the use of steroids in acute spinal cord injury. So although we have extensive basic science research on this, and this was one of my postgraduate research subjects, from the administrative point of view, our institution voted against the use of steroids in acute spinal cord injury at this moment. We're not even allowed to use this on our acute patients at this moment. Regarding the loss of C5 roots and the radiculopathy, it is clear to me that it is usually due to some pre-existing condition. I mean, the patient already had some loss of function of the at the C5 level that was subclinical, and it happens post-op. It happens unilaterally most of the time during our laminoplasties, and we perform laminoplasties on a weekly basis here, almost for trauma patients, and we do see some of them. Bilateral, it's really hitting the jackpots. I don't know if distraction by the cages could be one of the reasons. Usually it develops post-op. Is very rare that we detect this with neuromonitoring intra-op. But the good thing is that I've never had a case that did not recover.
Great. So we have another case, and we chose these cases just for you guys. So Dr. Nathan Pratt from University of Maryland is going to present the next case.
Thanks, Dr. Al. So the next case here is an 82-year-old female with cervical spondylotic myelopathy presenting with multiple falls over the past few years, progressively worsening bilateral upper extremity dysfunction and dysesthesias, dropping objects, now complaining of shooting pains, worsening over the last 2 to 3 weeks after another fall. Past surgical, she had 2 prior anterior cervical discectomy infusions. Now she's fused C4 to C7. These were for neck pain radiculopathy. She has a history of cervical cancer, depression, osteoporosis, and early type 2 diabetes. She stopped smoking 13 years ago, but has a 14-pack year history, uses CBD oil. Her exam, she has pretty profound weakness in the distal upper extremities, as well as in the lower extremities. She has a great deal of difficulty with any sort of ambulation requiring an aid. For that, and for any distance, she's using a wheelchair. Reflexes are 3+ throughout. Her Hoffman, interestingly, was not present. No sustained clonus in the lower extremities. The Babinski was mute on the right side, toes are down going, so no Babinski, no pathologic Babinski sign on the left. Light touch intact, except for the distal extremities have some hyposthesia. Here's her MRI. She's got adjacent segment disease, adjacent segment failure above the prior 4 to 7 ACDF at 3-4 there. She's got severe canal compromise and cord compression. Her CT and DEXA scan here, she is osteoporotic for what that's worth and has a solid fusion at that level. The management of her, she has this severe stenosis with T2 hyperintensity on her MRI. She has 2 prior anterior approaches to the C-spine, making approach through that incision very treacherous and probably not a good idea. History of significantly reduced bone mineral density and osteoporosis, and has worsening neurologic dysfunction. So she requires some sort of intervention. Patient was taken for a C2 to T2 posterior cervical decompression infusion. Reason we took up to C2, she needed a decompression at that 2-3, 3-4 region. She has relatively poor bone quality, so stronger anchor at the top and the bottom of the construct because she's already got a solid fusion in the middle there, a solid block of vertebra from 4 to 7, so needs something strong above and below that so that she doesn't pseudoarthrose. Surgery was uneventful. Patient's now actually only about a week post-op. Her pain control is improving from what I can see, and she's pending disposition at this point. Here's her post-operative. These are the CT images, the scout images. We don't have a post-op standing x-ray. And then here's her decompression performed. Hardware's in good position, cords decompressed. Briefly going to touch on autonomic dysreflexia after spinal cord injury. So this is often more of an issue for severe acute spinal cord injuries. Usually it's above the level of T6. The presenting symptom is usually severe hypertension coupled with bradycardia. The reason this happens is that the descending inhibition of the sympathetic reflexes below the level of injury is disrupted. This tract in the intermediolateral cell column is interrupted from the inhibitory neurons up in the medulla. They are no longer able to communicate with the sympathetics in the thoracolumbar region. Because of this, you have uninhibited increased systemic vascular resistance. And so the patient then develops severe hypertension. A baroreceptor response is triggered, which usually will drop the heart rate to try to compensate for this, but this is an incomplete sort of recovery for that. Pressures can be actually pretty substantial, up to the high 200s to the 300s millimeters of mercury in systolic blood pressure. It's triggered by a noxious stimuli of the viscera below the level of injury, which triggers this unregulated sympathetic reflex arc. This can occur anytime within the first few hours to months after an injury. This actually can develop late, though I would say most commonly as a resident, we would see it early, and we even very rarely see it early. Most often, this is caused by a bladder distension at the time of the injury. So detrusor, spasticity, and bladder distension will cause this type of response. Placement of a Foley catheter or bowel disimpaction often enough to sort of abate that. Medically, nitroglycerin will decrease the SVR by relaxing smooth muscle in the blood vessels. Calcium channel blockers like clofidipine will inhibit calcium influx in the smooth muscle, also lowering the systemic vascular resistance. Adrenergic antagonists inhibit the sympathetic response, but they don't affect the resting heart rate or blood pressure as much because they simply inhibit that sympathetic action rather than dropping the blood pressure further. And then Botox is used sometimes to inhibit detrusor spasticity that can cause this. And that is what I have.
Great. Nice job, Nathan. So we wanted,
One second, can I ask a question, Rod? Can I ask a question? So Emiliano, Luis, and Team Curitiba, you saw in this case two things. The first thing is we've come to really do a lot of very extensive posterior surgeries. They've become very fast and very efficient in our hands in elderly people with complex spines. So you saw posterior C2 to T2, and again, there's not a week that goes by that we're not using that. Are we too aggressive? Should we use more laminoplasties? That's the first question. And the second one will be these elderly, and this is what Nathan was referring to in his patients case, they have very complex hemodynamic management after surgery. She's obviously a myelopathy patient, but assuming that's like a chronic form of a spinal cord injury, hemodynamic management can be very difficult from very highs to very lows. Are these forms of autonomic dysreflexia like a form first? So number one, are we too aggressive with doing these extensive posterior fusions? Number two, autonomic dysreflexia is that under-recognized in our post-operative management of SCI patients. Thanks.
Yeah, got it now. The extension of the fixation is surprising to us, I have to say. We do a lot of laminoplasties without instrumentation, and we're not reoperating our patients if they don't have clear instability. And we're not seeing breakdowns. Maybe we don't have a long enough follow-up. But from we do have an economic perspective that we have to deal with cost management in Social Security patients. And a laminoplasty is, I don't know, maybe minimum 5 times cheaper than a long fixation like this for us. And cost-wise, a surgery like this would be really difficult for us. In our experience, in a patient like this, I would move on with a laminoplasty without any regrets. Maybe if she needs decompression at 2-3, I would go and drill the lamina, doing some sort of cutting of the lamina at C2 and C7. But we're not reoperating our laminoplasty patients. That's for sure.
So we have one more case. Jerry Robinson is going to present our last case, and then we can get on to the cases from our colleagues.
Good morning, everybody. My name is Jerry Robinson. I'm one of the Ortho Spine Fellows here. So today's case, 55-year-old with excruciating neck pain and arm weakness after a 300-pound table fell onto the back of their neck and head about a week ago. They were seen by a nearby trauma center, but were sent home with, quote, normal scans at that time. They have bilateral numbness and tingling in their hands. They can't walk and they can't urinate currently. Of note, they do have type 1 diabetes and CKD stage 3. Here you can see the exam, somewhat like an incomplete uppers worse than lowers, Asia D, spinal cord injury, and loss of dermatomal distribution in bilateral hands. Here you can see 1 week ago in the read from the radiology report that said there's nothing wrong here. Pretty remarkable. But either way, this patient was sent out as is currently here. Wow. Then they walked in, or not, didn't walk in, but was brought in, and this is their imaging now. You can see AO type C, dislocation of C6, C7, bilateral facet fractures. An MRI was obtained by the ER, and then that's when we were consulted. You can see the bilateral jump facet fractures, Asia D, and then an anterior ventral hematoma. So plan at this point. So the patient was had a Foley, a glide scope intubation with manual neck immobilization, Gardner-Wells tongs, 5 pounds. It was grossly unstable at that point. We did give steroids, bolus as well as infusion, and an insulin drip to manage their diabetes. And then they had an open reduction with ACDF with bicortical screws as stage 1. Here you can see our metomyelogram, as Dr. Chapman likes to call it, proving our decompression. Here you can see excellent realignment and anatomic alignment of the spine. Here's our postoperative CT showing that good alignment. Then stage 2, patient got a C5 to 7 with lateral mass and pedicle screws as well as laminectomy. And you can see our 3-month follow-up. The patient is 5 out of 5 with sensation intact. So luckily, crisis was avoided here, but likely this patient will suffer some spasticity or other sequelae from their spinal cord injury. And so this is just a credit to Yev Fravert, our neurosurgery spine fellow here. He's unable to be here, but he sent me a slide basically going over bladder dysfunction in spinal cord injury. So with a normal bladder, you have descending pontine spinal input. You eventually get detrusor contraction and then urethral sphincter relaxation that allows the bladder to empty. And so you have unobstructed urine outflow. With a spinal cord injury patient, you have disruption of this spinal input, and you have the dysregulation of the natural relaxation and contracting of the detrusor muscle and sphincter outflow. And so you have obstructed outflow of the urine with elevated pressures. And then one of the areas of research that Yev is undergoing or an area of potential future treatment is that we can try to modulate this pontine spinal input to try to bypass those discoordinated muscle contractions and relaxations to restore normal urine outflow. This is just an area of research currently, but a good slide demonstrating the difference between the normal and now the interrupted bladder function during spinal cord injury.
Great, thanks, Jerry. So one question I have for our colleagues and Jens, what do you think? Do you think we could have just done an anterior surgery on this case?
Let me pass on to Emiliano and Luis. I've actually, when I was in Curitiba in their trauma center, I actually saw a neck dislocation being managed acutely. So the principles, I think, internationally have become very similar. But let me ask you a question. You talked about economic feasibility. Is this something you would have just done anteriorly?
Yes, but I guess the main pitfall here is the size of the cage, or the spacer or the inner body that was used. You can see there's a clear distraction of the facet. So what we try to do is to use the smaller cage size for trying to realign the facets. The only indications for 360 fusion in the cervical spine for us would be multi-level injury. A case where we would have the facets not clearly unreduced, or if we have a separation by like a pedicle fracture, or in a case like this, where in the end of the case, you realize you had over distraction of the anterior space. You can see that clearly the space is disproportional to the other levels. So in this case, after surgery, I would recommend a posterior fixation. The other thing that I'd like to comment is on the use of the, you see there's a transverse connector. Often I see this is a source of hematoma, source of wound dehiscence, and a source of non-union and posterior fixations. We rarely use cross connectors in the cervical spine. How often do you guys use? Is this a regular basis for you? Use a cross connector on the cervical spine?
I love the posterior connectors, and I'm curious to hear Rod's opinion. The reason is I think they're a great prosthetic lamina. they clearly, in multi-levels, in this case, it's very arguable. In this case, it's a relatively short segment fixation, but in long segment fixations, they prevent the so-called parallelogram effect, the lateral or coronal plane tilt. So mechanically, both in rotation and coronal plane fixation, they add substantially, like 30 to 50% plus fixation. Finally, it does prevent that secondary scar formation in patients, and Dan Rue has actually shown some very nice cases with this. So again, this is the lambda effect. And finally, if you have to go back in years later, it is the nicest thing on planet Earth to have a little friendly metal guide to get back in. So those are my thoughts, but I don't see a downside, and certainly in terms of wound infection or dehiscence, we've absolutely not seen that. But I recognize that posterior incisions always have a higher risk for that, and a very meticulous soft tissue dissection and closure is necessary. But your thoughts?
Yeah, I mean, I love them. We call them artificial lamina. I mean, they're going back in, and then I do think they provide extra stability. So I think when we can, especially for posterior cervical fractures, I think they're ideal. So do you guys want to present your cases? You guys have a couple scoli cases you want to present, and then...
Yeah, this is we're gonna have two cases. If
Okay.
Dr. Guasque wanted to put up her case, this is a neuromuscular case, so it's a little bit involved with neurologic issues, and the other case is the Charcot spine. So I just want to hear your thoughts on how to manage this.
Hi, good morning. My name is Joanna. I will present the first case. So this is a girl, 12 years old. She has a lumbosacral myelomeningocele. She can't go to school because she can't use the wheelchair. She has dyspnea and continuous low back pain. She has a cystostomy and rib surgery. So this is her X-ray with a very high lordosis in the lumbar spine. Her MRI. So the questions are, should hyperlordosis be correct? Will it make a difference for her? And how to approach it with plastic surgery to do, to involve, to close?
So both Rod and Jens, would you like to comment on this? Her ribs, hips, she had some sort of flexion contracture, but she had previous surgery on the right hip, so they're moderately flexible.
Yeah, I think you preempted my question. So there are multiple factors. One is obviously the cerebral function of the patient. If the patient has normal or near normal cerebral reasoning and functioning, that's obviously very helpful. Nutrition is a really big deal in these patients. I'd make sure that they are as well nourished as possible. I didn't quite see the MRI. If you don't mind going back to that MRI scan to look at the neural canal. Okay. Yeah, so that's a very complex disorder with a complete prolapse. If you don't mind using your cursor to show how far the meningocele goes out. She has an L1 level, or what's her level? Does she have?
So, yeah,
her neurologic level?
She's paraplegic at L1 level. She has no function of the lower limbs, and she has normal cognition. So she's perfectly functional kid.
I would get PFTs, so pulmonary function test. I would get nutritional optimization. I would try whatever I can with stretching to try to have the hips mobilized. Hyperlordosis is one of the hardest things to correct in spine. I would certainly have my neurosurgical colleague and my plastic surgery colleague on board with this. Dr. Huang, our good friend, Dr. Huang, I want to welcome him. He thinks that the cord is tethered also, and I agree that the conus, if you can go back to the MRI scan one more time. Oh, yeah,
I'm sorry.
nice.
I'm
Gave
sorry.
it away. Yeah, so the conus looks
We saw
very
what
low.
you
This is typical.
Busted.
I would do what you did.
I'm sorry about that.
Thank you, Dr. Glasky. Thank you.
But the question is, will you detether it also? And again, that's a really big question on L1 complete. And Dr. Huang, Robert pointed that out. Since we always love having our conferences together, he always points out very important
the
things.
more difficult thing in this case is the closure, and then the distal and hip and pelvis and hip, because, and the fact, I think Jens and you guys pointed this out, is, this is someone that's paraplegic. So getting the wound to heal. So what did you guys, not to steal your thunder, but what did you guys do for the closure and the pelvic fixation and the tethered cord?
So, do you want to show the results? So the main difficulty here was clearly surgical positioning, and to find a way to clearly correct the patients. So this looked like it was going to be a nightmare, and we had plastic surgery involved. It was really easy to identify the filum terminale and to release it during surgery. And she had no function, so we didn't even use a neuromonitoring in this case. But in the end, we did not need plastic surgery to do the closure. The great difficulty here is to make the decision towards where to stop the fixation. So we wanted to use iliac crest graft from her. So I chose as not to go into the iliac and to use bicortical fixation into her sacrum in this case.
So, Emil, in our experience, someone who's paraplegic, not having pelvic fixation is going to be an issue if that doesn't heal.
Yeah, the difference here is really the nature. As she's trying to pull back and not forwards, I would not expect a big lever arm on her pelvis, and so that's why. And due to the poor coverage that we had over the very little skin and soft tissue over the iliac crests, even the S2 iliac screws look to be prominent. This was our concern as well. We had a lot of graft for her. Iliac crest graft was bone bank graft. And this is like a unique case that had been neglected in several places for many years. And clinically, the result was astounding. So this is the post-op. We had lots, actually, after we did the release of the contractures and the muscles, we had lots of skin to cover up. So we did not need to use the plastic surgery team to run any flaps for this.
Beautiful.
And this is
absolutely gorgeous.
Yeah.
This is her.
Congratulations.
She was able to sit without using her hands, so she's fully functional. She had a couple of hip surgeries later on this course, and after this, she 4 years after, she started with a hip infection, which spread over to the spine, and we ended up removing the hardware, and we could see she had a solid fusion. So we took off the hardware 5 years after surgery without any compromise to her alignments.
This is an absolutely beautiful case, and so gratifying to see. I agree with Rod that my worry would have been lack of pelvic fixation. The long-term outlook of hardware in patients with chronic paralysis is obviously very difficult. And I assume that the hip infection is after anterior hip releases, which in my own practice, when I used to be at Children's, also was very frustrating. These anterior hip release patients, they have a very high propensity towards infections of their hips, and I'm not sure why that is. But in terms of indication and performance, I think you guys did a phenomenal job. The only question I would ask, and again, your outcome speaks for itself, is what's the role of shortening osteotomies? Some of our colleagues in the US, specifically in Baltimore and in Philly, have suggested to do shortening osteotomies, where you basically resect T12 or L1 and L1 paraplegic. That could be an option so that you can kind of shorten the spine down and bend it forwards to enhance sitting posture.
I guess that the main trick here was to do an extensive release, like the old neuromuscular scoliosis cases. So release all the muscles from the iliac crests and insertions from the thoracolumbar muscles, and that basically released everything. So we did Ponte osteotomies in gradual correction, and I just found that in the end of the case, doing a shortening vertebral body osteotomy, or I would have to do like a reverse pedicle subtraction. There was already too much surgery for her at that moment. So we stopped, and we were happy with the opening that we get and the correction that we got. But that was maybe the background strategy if things would not go well with the soft tissue release.
Okay.
Do we have time for a second case before the presentations? How are we running on time?
Yes, we do.
Perfect.
Okay, so Luis, you're on.
Yes. Okay. This is our second case. This is this is the story of a 30-year-old male who sustained a motorcycle injury 11 years ago, and was a very severe traumatized patient. Looking to the spine, had a T4-5 type C injury with a Asia A complete spinal cord injury. He was operated on in another facility with a long fixation all posterior, and he did well for a long time. But in the last 6 months, he started with some symptoms of dysreflexia autonomia, like increased spasticity, spastic bladder, headaches, and other things. So these were leading us to think that he has something wrong. And this was his images. These are the x-rays. You can see clearly that is something wrong in the lower level, the first level below the fused spine. This is the area of the original fracture. And as you can see in the bending x-rays, it's able to see that there is mobility in this area. As you can check that the disc opens up in the extension x-ray. And this is the image. This is the residual deformity of coming from the initial trauma, but this is the area with the new pathology. This patient has some labs with chronic anemia. The erythrocyte sedimentation rate was over 60. But the blood cultures were negative. The question is that this situation generally entraps surgeons to think this is an infection. Sometimes it is an infection, but there is this special thing that happens in the spinal cord injuries patient, which is the Charcot spine. And we have some experience with this case, and we have considered this patient as having a Charcot spine, which is a neuropathic spine, much more than an infection, because we had no sufficient information to clear the patient as having an infection. So there are many options regarding this the surgical treatment, and this is very hard to do. We know that these patients have little biology in the area, so these patients hardly get fused. The strategy was aggressive debridement in the area. The approach was 100% all posterior. A cage was put in this disc space with some compression to put bones in contact to shorten the posterior spine. Three fixation levels were added below the area to stabilize the spine, and the connection of the rods were done. Lots of leaky crest bone graft was put as in favor to get healed, and we used a satellite third rod, as we see growing evidence in the literature of the use of these satellite rods for deformities and long fixations. But the problem is that the quality of the bone healing process is very compromised, and these patients normally get unfused. They evolve with non-union, and this patient is having already a T11 screw breakage. And but this is to show you how we treat these Charcot spine patients, and I will end up the presentation with a question. I know Jens has a lot of experience with these cases. We have in Brazil lots of, we don't use BMP on a regular basis as you do in the US, but my question is there a secret for these patients to get healed, Jens?
This is a very timely presentation, and I'm at the end of this. So thank you, Luis, and it's so nice to see you again. And you look great. You look unchanged from 20 years ago. Congratulations. Life in Brazil, right? You guys do beautiful work. This is very timely because one of our very good friends and part-time faculty, Dr. Ed Farah, a fellow spine surgeon who's a T2 paraplegic, he's taught many of our courses, just recently decided to end his life because he had developed a severe Charcot arthropathy that went up into his shoulder girdle. So he actually became triplegic from what initially was a T2 paralysis. And he was such an active person that he actually decided that he wanted to pass away with death with dignity. And I'll send out a link for all those who want to hear about this remarkable life, but also what it means to be paraplegic and what it means to have Charcot breakdown, which is highly under-recognized. Most of these patients kind of just feel sick. They don't do well. They have some vague pain, and then they get treated for osteomyelitis or discitis and get endless needles and this and that, and they have a mechanical breakdown. But the problem is that you're obviously having to sacrifice more and more motion segments, eventually down to the pelvis, and that has its own toll. So this is a very difficult thing. In our publication, we've basically learned that this is where 4-rod constructs that are mechanically very strong with large screw fixation does help. You shorten the spinal column. And yes, we use off-label bone morphogenic protein. Yes, we use cages. But for us, the biggest breakthrough has been recognizing it, first of all, educating the patient, having occupational and physical therapy and rehab medicine involved, so that they change how they transfer, they change how they do sports, and to working with plastic surgery for closure, but having a very rigid mechanical fixation with usually 4-rod construct makes a big difference. And again, sometimes when there's acute pus in there, staging it, where we put PMMA antibiotic spacers into the defect zone, and then exchange those for a cage and bone graft with off-label bone morphogenic protein. So those are our thoughts, but thank you for showing this case. Thank you for highlighting this problem.
Yeah, just a quick question. Would you have considered going lower than 3 levels?
No,
or
I think that the main thing is that you want to preserve motion, but these patients have to change how they're mobilizing. So I found that they frequently have a hatred towards that non-functional lower body, and they whip their body around. They kind of torque too much. They do too much lateral bending. So they have to change anything from how to sit in their chair to how to transfer and how to relax their spine more often. And it's very easy for us to say that. It's very hard for patients to actually do that, but they do require a comprehensive rehab intervention. I would have done exactly what you have done. I would have probably used a different construct, but I think the principles are very much the same. Again, I would have, based on what I now know, done a 4-rod construct over the troubled zone. I would have ended at L1. I would have told the patient, look, this is a march towards the pelvis over time, unless we can somehow change how you mobilize.
Thank you.
By the way, we've added the link. So in the chat room, you'll see the link for our late colleague. Dr. Ed Farrar, and I encourage you to watch it because there are 3 different programs, but the last one is rendered by our good friend, Dr. Ted Wagner. And again, this is a spine surgeon. This is a very active spine surgeon who succumbed eventually after extensive counseling to a Charcot arthropathy. He decided to end his own life, but this is real. As we're briefly talking about that, what is very important to notice that these patients can have ascending paralysis, which is due to a Charcot arthropathy, basically creating a cyst formation or fluid formation that destroys the cord rostrally. So these patients do require a spine surgeon follow-up probably every 2 or 3 years, together with a rehab doctor who looks for upper extremity deficits so that the disaster that happened to our colleague does not happen. So ascending paralysis is real. Weird neurologic changes with a change of the transition zone sensation, for instance, are very concerning findings and do require further advanced neuroimaging. So I cannot tell you how much I appreciate you sending this or showing us this case.
Okay,
Shall we move
thank
on
you.
to the featured presentation?
Yes, I'll try to make it quick, and it's again a pleasure and an honor for me to be able to present our stem cell therapy. This is part of the postgraduate program in health sciences at the Catholic University of Paraná. Just as a brief location, we are located in the city of Curitiba, which is in southern Brazil. It's a city of little bit around 2.5 million inhabitants. We're part of the Spine Group, which was founded by Dr. Luis Vialle in the early 90s. This is one picture here down here where my father and our head is torturing one of the residents. So you guys, residents and fellows, are happy that you don't have my dad as a mentor. If you don't present well, that's what happens to you and here in Curitiba. He has trained, along with our team, more than 100 surgeons from Latin America, Europe, and Asia. Our main focus, as you guys seen, is trauma and adult spine pathology. Although we do get a lot of pediatric neglected deformities, late presentations, and we do a lot of neglected metastases that come out to our trauma wards. This is our lecture outline, and as you guys know, Brazil is well known for soccer, or for football, as you call it here, for our carnival, or maybe for our beautiful beaches. But what you guys might not know is that we are the world champions for spinal cord injury. Brazil has more violence-related spinal cord injury than any country at war currently. And it's ranked 3rd place in motorcycle-related spinal cord injuries. We see on a weekly basis gunshot wounds to the spine. This is an image of a knife crossing the spine and hitting the vena cava on a complex case that I'll be glad to share with you guys at some other opportunities. So we have huge needs to get people back into their functions, and there's some investment on spinal cord injuries. You're all aware of the difficulties regarding cell therapies, regarding sources, isolation methods, and the different way people analyze their results. Not talking even about commercial biases, because this is very tempting for patients to get into a lot of insecure trials and therapies. What we have been doing for the past few years is to use mature adipose tissue cells because they have a high differentiation potential. They have a paracrine effect. They do work on immune modulation, and mostly because they have a low immune response. Just for a quick brief, this is a systematic review that was part of our postgraduate program. Looking at the way people are dealing with stem cells in the literature. There's a tendency towards the use of scaffolds for implantation of the stem cells, and a combination of mesenchymal stem cells with neural shunt cells. But you see that more than 50% are undifferentiated mesenchymal stem cells. And I'm pretty sure that if you look at the literature, this is not going to take you anywhere. Most of the results are uncertain or negative. So we should really look at neuroprecursors, olfactory initiating cells, umbilical cords, Schwann cells, and as our research line has looked in the past few years on adipose tissue stem cells. If you look at the way cells are delivered, you again will see something that has not worked, but that people consistently try uses is that injecting it in the injury site. And this is what we have been done with unsatisfactory results in our experimental models in the past few years. So we have shifted towards a different strategy, and this is what I'd like to share. What we have been doing is to use the cauliquina as a delivery method and gradually stimulates cell migration. The difficulties was really to know whether cells would migrate towards the injury sites and how they would act on the acute spinal cord injury. So this is our experimental delineation. And basically, we do have a standardized model, which is an evolution of the previous NYU, now known as the Rutgers impactor for producing spinal cord injury. And this is a mid-thoracic injury on the rats. The other part of the difficult part of the research is to obtain the adipose human tissue. So we do have a lot of plastic surgery in Brazil. So fat tissue is not a problem to obtain. We do have consent from young patients to use their fat cells and to follow the enzyme digestion and all the preparation until we have around 80% confluence or cellular confluence on the plates. And we do a phenotype analysis, immunophenotype, to see that these cells have not differentiated during culture. And we do inject around a fair amount of cells per microgram. The interesting part is that we're able to use cellular transduction. So we injected an enzyme into the cells, which is bioluminescence. And by taking pictures on a dark chamber, we could track the presence of these bioluminescent cells by adding the protein that this enzyme digests into the mouse. So we could see that we could follow for 7 days and up to the end of the experiments, the migration of the cells towards the injury sites and their survival. So what could we find? So we had excellent cellular kinetics. So we could find good. We did not lose a lot of tissue during the culture. Or we had flood cytometry 20 days after culture. We could show with the basic histology that we had reduced injury, although it was not significant regarding the reposition of myelin. But what we did found is that with this experimental group, we had lesser extension of injury and a significant amount of neurons in the injury sites, which was not clear if it was due to a stimulation of reproduction, but probably due to the reduction of secondary injury to these animals. We could see, we expected a reduction, a significant reduction in astrocyte activation. And I guess this is the main limitation of our research project right now, how to limit astrocyte activation and glial scar formation in the injury. We also used the FISH method for identify the active transplanted cells. And we could not find after 40 days after injury, but up to 35 days after injury, we could find active cells surviving in the injury site. These are some interesting images of the cell migration. You can see where the image starts. and then they migrate towards the injury sites. And at day 7, we had around 20% cyno. We still had cells alive. We had only two animals where we had systemic spreads, one to the brain and another to the lungs. It's not clear whether we injected the dural sac into a vessel or an artery, or just an extravasation of the injury. As a conclusion of this first part, which lead us to the second part of the research that's going to be presented by Dr. Arruda, is that we could get cells to migrate towards the injury sites. We could reduce injury severity. We could reduce some scar formation, but we could not make these cells differentiate into neuronal cells, even with the further steps of neurostimulation. And we could not prolongate their cellular life. So there must be a second step, which is going to be presented by Dr. Arruda, to make these cells that can be easily injected into the dural sac and migrate towards the injury, to stay alive longer and to differentiate into neuroprecursors. Just to acknowledge the support that we had from the Catholic University and the cellular technology team, and the support from AOSPINE Latin America to this project. We can move on to Dr. Arruda's lecture, and then we can discuss with the participants.
Are you able to see my screen?
It's black right now.
Okay, so I'm gonna share again. 1 minute, please.
Yeah, just click back your slides because you're in the end of the slideshow. Just send them back, move back.
Yeah.
Yes, there you go.
So good morning all. Thank you very much for this opportunity. My name is André Arruda, and I'm gonna show a bit about our last topic of research that we are given more time right now. So we are talking a bit about biomaterials and stem cells in spinal cord context. By these last years, we could see increased number of studies regarding innovative delivery systems, considering the stem cells and the spinal cord injury context. Also, we could see the development of highly compatible biomaterials, especially regarding to the polymers use. So there are some positive interaction between stem cells in cell culture with this kind of materials, considering the positive effect on their differentiation and also their positive modulative local effect. There are some still challenges and opportunities regarding this kind of combination, which means biomaterials, polymers, stem cells, and spinal cord injury. By now, we all agree that we need to minimize the medullary tissue manipulation, and there are already some kind of possibilities to do that as the distal infusions, as Dr. Vialle just showed us. And also there's another opportunity that once we indicate the surgery treatment for this kind of patients, we have surgical decompression and also the tissue exposition, which means the medullary tissue is ready to receive cells and or polymers together. By now we have the main concern that we need to develop or we need to create an ideal delivery system which can be useful in the meaning that don't increase the local pressure, because if it happens, we're going to have an amplification of the secondary lesion cascade, and at the end, we're going to have poor clinical results, worsening the patients. Having that, we need to study, or we are studying at the positive potential effects of the biomaterials in the combination with stem cells and also in the spinal cord injury therapeutic area. First of all, we have this kind of opportunity that the biomaterials can replace the anatomical structure which is just damaged. Also, there's another interesting point that this kind of materials, they can mimic the extracellular environment of the local tissue. They can carry also active particles, and they can act as cell scaffolds, increasing or also having better results considering the stem cells interaction. And they are already available in a wide range of presentations, which means hydrogels, the membranes or the scaffolds, and at the end, these fibers or nanofibers that we're going to show you a bit more. Specifically, the nanofibers, they have the positive points that they can mimic the extracellular matrix architecture. They can work as a functional scaffold. They are presented in a ready-to-use way, and they also allow the direct deposition over the medullary tissue. There are also some systems which are already available as the electric spinning. It's a method that is well established for membranes fabrication. On the other hand, it involves really high costs. Because of that, we are looking for a different or a new way to produce these nanofibers to be used in this spinal cord injury, maybe patients in the future. So we studied the solution blow spinning or the SBS system, which is non-harmful, and most interesting, it allows a translational research, which means it uses just the equipment which are already available in a surgical room, and it also totally made in under sterile conditions. Basically, we have a really simple system which needs a gas pressure as the source of the system, syringe, needles, and by some standard parameters, we can produce some fibers to deposit or to go after the local tissue. First of all, our first step of research was to fabricate the system construction. We used some low-cost materials, and we established the parameters standardization, which were really important to us to produce the fibers. In a second stage, we looked after the ideal polymer or the ideal biomaterial to work with, and our choice was the PVA, the polyvinyl acetate. We then tried to find the best presentation or the best combination of the biomaterial characteristics, meaning the molar mass, the viscosity, and also we worked with distilled water solution. So we won't need any kind of toxic solvents in this polymer solution. And at the end, we had the nanofibers fabrication in ideal conditions for mimic the extracellular matrix. Having that, we could find the ideal polymer solution with good entanglement between the fibers and basically with almost without any kind of water droplets, which means during the fiber fabrication, we had the solvent totally gone. After this production steps, we started to learn or to try to understand how would be the cytotoxicity tests or the interactions between cells and our nanofibers. In general, we could see during the first 48 hours, we could see the cooling down process, which means a decrease of cell viability. And after the 48 hours of exposition, we could see, on the other hand, the ideal environment for cell proliferation. That could be maybe more clear for you when we talk about live dead cells. So we had two kinds of tests here. The first line or the upper line, you could see this cells lines tested with this interaction, which means PVA nanofibers. And the bottom line, we have the medullary red cells in a combination with our nanofibers. In general, we have the green dots, meaning the live cells, and the red dots, meaning the dead cells. We could see here until the 48 hours of exposition to our PVA nanofibers, we had the increase of the cell death rate. And after that, from 72 hours until the 7 days, we could see the opposite way, meaning an interesting local environment for cell viability. Taking that as the, let's say, for the last time or the last time point for this stage of our research, we also tested our nanofibers in an ex vivo animal model, applying these nanofibers in a ready-to-use application directly over the medullary tissue. So we could find a really interesting and high adhesivity of these nanofibers directly to the spinal cord. And after 72 hours, we also could see a total biodegradation, meaning no more nanofibers locally active. So for the future directions, we would like to invite you to talk with us during the Global Spinal Congress when we have the opportunity to present our results. And we also working already with double SBS system, meaning a cell spray system combined with our nanofibers. And also we are looking for maybe more interesting results using another products in our polymeric solution, combining with graphene, which increases the electricity conductivity. So that can be interesting. Thank you very much for this opportunity. And I'm at your disposal if you would like to comment or have some questions. Thank you.
Outstanding. Applause. Rod, do you want to take any first questions or do you want me to go ahead?
You can go ahead, Jens.
So first of all, in retrospective introduction, Dr. Emiliano Vialle and the team in Curitiba are outstanding leaders in our field. I, as a visiting professor, was able to see them firsthand years ago. And this is a dramatic example of a city that we frequently ignore. It's a very large multi-million city in South Brazil. The Catholic University in Paraná is a outstanding intellectual breeding ground, as you can see, with really bright young people. There's a very large mission population there, which I was very impressed with. So all of us who live in and work in inner city hospitals like we are really can see how difficult it is to treat large numbers of patients with a very significant economic pressure there. And despite that, they do an outstanding job. Dr. Vialle and his team are well recognized around the world, and especially in the EO community, have been true leaders in the field and tackle complex issues, not just directly clinically, but also in the research space, such as in spinal cord injury. So congratulations on your work, both in basic sciences, as you've shown, and in clinical practice. And I'm conflicted because Dr. Vialle is a co-author in many articles, and we serve together in several committees. And that goes to his entire team also, who really have been superb contributors. Here are some questions. So as we look at spinal cord injury repair, there are three basic things that I see as challenges in spinal cord injury repair. One is cellular viability. Number two is cellular organization. Then number three is functional restoration. So as the first step, the first presentation was excellent in terms of pointing out the theory of converting adipose stem cells into meaningful neuronal cells. On the overall picture, if we say 100% is we can now recreate neuronal cells, Dr. Vialle, where are we in this trek towards having viable nerve cells that we can put into an injury zone that we can expect to actually fulfill a nerve cell function?
Oh, this is a great question, and the answer is very positive. Maybe 20 years ago, I would not expect to see nerve cells growing and making physiological reconnections like I have seen in experimental models. I'm pretty sure that this is not going to be a one answer option. This is the adding of cellular to biomaterials, to neuroprosthesis, and to some sort of genetic, probably genetic regulation towards the scar formation and the regulation of healing process inside the central nervous system. So this is one piece of the puzzle that we're trying to solve. But the only answer to that is that more and more multi-institutional consortiums should work in different ways, and share their knowledge to get into a final conclusion. I guess that's the work that I've done and that Dr. Arruda has been doing can be added into one step. And we do have people that work with external neural stimulation here, and that has shown to be really promising towards creating a positive environment for physiologic reconnection. So having the correct stimulation is another part of the research project. And this is right now, this looks really complex, and but it's still we're moving faster than towards a solution than in previous years.
Have you isolated what neurotactic factors stimulate this migration of your adipose stem cells? What signaling is taking place that attracts this migration to happen?
So this is not in this research, but adding neuroprecursor stimulators like obtained from fetal embryonic cells, or for the fetal embryonic neuroprecursors from the umbilical cord, which raises less ethical issues, is the best way to stimulate. The migration was really fantastic. The differentiation is where we have been struggling right now. So even if we can stimulate the migration towards the injury sites, the neural differentiation outside reduces the neural differentiation outside the human body, increases the body response, the immune response against the cells, and increases its survival. So the solution is to get the differentiation inside the spinal cord, and this is the tricky part because it takes a long time and the cells do not survive.
So the survival, again, we've made significant progress. You have shown impressive findings there, but this brings me to part two, and that is the best examples that I've seen of stem cell or neurocell derivative survival leads to something that looks like a mess. I'm not critiquing your study, but these are other studies where when you look at it, you can see nerve cells survive in this kind of a spinal cord injury zone, but they are just a convolute of something. It certainly does not look organized. So this is where the structure comes in. And again, this was really cool to see your approach towards that. How do you align the ultrastructure to kind of get it to be collinear so that nerves can kind of form into a pathway and not form this kind of a jibber-jabber mess? Do you use any I missed that part. Do you use electrostatic impulses or something to get these structures to set up in an aligned ultrastructural fashion? What logic do the ultrastructures and membranes use to form into an organized pattern?
Andre, do you want to answer that?
Yes. So thank you very much for this observation. It's totally the truth regarding the kind of the complexity, the level of the complexity that we need to achieve using materials also. We are looking for that. So by this moment, we already know that this kind of entropy, it means this level of non-organizational or non-really well organized fibers can be interesting for cell survival, for cell differentiation, and also there may be using external stimulation. It can works more functionally, not really needing the totally organized architecture local. We are looking, our recent studies are looking with graphene, which can send some positive signs for conduct electricity. So maybe the cells can have more potential for differentiation and also to organize it, to be well organized in our mass of something or stem cells. Maybe I will look for some another potential materials such inorganic or organic materials such as graphene can be interesting. So, but we totally agree that sometimes we just find a kind of mess, and we are trying to find some ways to refine this kind of results.
Yeah, Dr. Oskurian, pre-COVID and we were in Germany. We saw in the lab how they used actually hematoma materials, organized hematoma materials, and then they sent an electrical current through to try to align fibroblasts into a kind of a meshwork. So this is obviously something that is a very hot button topic. And I, again, think that your work already is outstanding in this regard, which brings me to the function part. So does it help as we're trying to isolate cells and having some ultrastructural thing? Do you think that function to provide these cells with a purpose as early as possible is the possible missing link, so that from very early on we have some functional current or something like that going through the area in question to provide alignment?
Yeah, we totally agree. That's the way that we're trying to, and that's not easy to obtain that or to have this kind of signs or these pre or really early signs for ideal differentiation. But let's try to gonna find a way to achieve that. Let's see in the next years.
So this Tariq Sohail, by the way, from Lahore, Pakistan, is with us. He's a frequent contributor. So welcome, Tariq. Any questions or comments from your end from
Thank
Pakistan?
you. Thank you, Jens, for kind introduction. Is there any role for exosomes in regenerative capacity of the spinal cord injury, where once it's established that the recovery on its own is not going to take place, and the whole process of gliosis and other processes that set in, and there's no more progress. I understand a study from or the trial from Indonesia. They have some very good results that after injection of exosomes into the thecal sac, the patients started moving their legs, and they were starting, improving quite rapidly after a few weeks' time. Is there any science into this, or whatever?
Okay, I'm not sure
Yes.
I got the main point of the question. I'm sorry.
So
Yeah.
let me rephrase.
Is it
Tariq's
a role
question.
of
Tariq,
exosomes
let me
in-
take a stab at it. Tariq, let me take a stab at it. Timing of
Okay.
intervention. Should we wait until we have full gliosis and a complete spinal cord injury and all whatever large cyst formations, serine formations, or should we intervene earlier? And when is the optimum timing for such an intervention in a hypothetical future? I hope I'm doing it justice.
I can speak from the basic science point of view and from the experimental spinal cord injury point of view. It is clear to me that time will be acute injuries and chronic injuries will have two separate strategies. Currently, it is easier to reduce astrocyte activation and reduce gliosis than to take it off and replace it. So I don't know if I'm answering your question correct, but the best strategy right now is acute implantation. Chronic implantation is very difficult to grade, especially because spinal cord injury animal models tend to develop a lot of complications very early on their courses of spinal cord injury. And the clinical studies that have been using cellular therapies over patients with chronic spinal cord injury, they have severe limitations towards the clear results over complete versus incomplete spinal cord injury as well.
So what I'm saying is that is there any role of exosomes, which are basically growth factors derived from the conditioned cell media, and they inject them into the thecal sac, and they have been some promising results in Indonesia. Do you have any experience, or do you have any comments about this, or any your thoughts about it?
Yeah, I guess this is going to be another part of the puzzle. Having the right neurotrophic factor that will most neurotrophic factors, they end up increasing astrocyte activation, and you get more fibrosis later on. So this is another part of the puzzle. Maybe adding what I've done with my colleague, Dr. Arruda is doing, and adding more advanced neurotrophic factors and probably genetic manipulation of the stem cells will lead to a better results. I totally agree, and this is a great comment. Thank you.
Now, let me ask one more question there. We talked about steroids earlier in the clinical case presentations, and I think we can all agree that there's no question that steroids prevent membrane swelling and neural membrane unraveling. So all that you've said, why would we not give very good high-dose steroids for 24 hours, like what our own AO Spine recommendation said, in true spinal cord injuries, to limit the zone of damage, to get that secondary injury zone to stay focused? Why not, with appropriate precautions, obviously?
No, I totally agree with you. When we get to this discussion, there is a lot of the limitations of the data are what's the clinical data is what makes us struggle with the high costs of the steroid therapy currently. And but from the basic science point of view, there is bulk evidence that you reduce secondary injury and that you reduce neuronal loss by applying early steroids into animal models. I totally agree, and I've got into discussions where people become very personal about this matter, and they don't assume that this should be used outside of an adequate research protocol. So right now, the status is that we do not have strong evidence to support its use outside of another randomized trial or something like that. So these are still ongoing. If I could, I would be using steroids in my patients.
Yeah. As you saw in our cases, we use it, and again, sometimes it doesn't help. Whatever causes C5 palsies in the case of mine, it didn't prevent it, despite having a very uneventful, very clean surgery. So this is still a complex issue. Before I pass the microphone off to my partner, Dr. Uskuyan, who did a great job, and I want to thank him for organizing this, I want to point out Team Curitiba. It is so nice to see you. It's sad to see you remotely, but it's so nice to see you. I'm so impressed with your work, and I wish the son of Dr. Vialle, who's competing in the Brazilian National Tennis Championships, all the best. I want to hear the results later. Great-looking kid, great-looking family, and a superb athlete like his dad was. So congratulations on your work and best wishes for a successful tournament. Rod, give us a big picture perspective and send us out. And by the way, May 18th, Wednesday, we're going to continue our Latin America tour. We're going to go to Argentina with Dr. J.P. Guyot, who's going to talk critically about MIS surgery. So visit with us for our next TED Talk, May 18th from Buenos Aires. Rod.
Terrific presentations, great lectures, and very inspiring work you guys are doing.